thank you so much. Thanks everyone for being here. Now we're gonna try and take as little time as possible from our speakers, and we want to thank them heartfully here. We have 3 wonderful speakers, and welcome also to the Weight-Bearing CT Society. I was supposed here to give you a little bit of insight for those who aren't acquainted with us. The society was founded in 2016, in 2017 officially, but it was co-founded in 2016 under the guidance and presence of Professor Martin Richter from Germany. With the advent of weight-bearing CT, so this great new technologies that is changing everything for us as clinicians and for our patients. So to this date, we have 110 members across all continents, mainly foot and ankle surgeons, but now more and more academic affiliates, radiologists, nip and he surgeons, and we hope soon also spine surgeons. The goal for now is to increase our visibility and increase the scope of our activities. So we also encourage you to all join the society. We hope in the future that there will be more and more of us to push this technology forward. We have a number of missions, which is to promote and improve research using 3D radiographic imaging with weight-bearing CT. We also have an ongoing task force looking at standardizing the methodology regarding measurement methods. That means defining methods for measuring things in 3D, because it's a new world, 3D for us in orthopedics. We also are promoting research and publishing a number of papers on an international level. I wish to state the membership is still free, so it's a great time to join. I encourage you to go to our website and get as much info as you can. There's the slide about our board. So I'm current president, and we have people from all over the world. And we're trying to maintain a balance between the Americas and Europe, and hoping to get soon into the board people from Asia as well. Next slide, please, Tanguy. I especially want to thank our sponsors, so Curvebeam, Paragon, PlanMed, and Disior. I'm sure you know now that Paragon and Disior are just one company, but anyway, they have been supporting us since the beginning, and of course it's very essential, because nothing would be possible without them. And now I'm on to giving the mic to you, Tom, to present us OCTA research. And I also wish to say this is our very first joint meeting. I hope there will be many others, and the goal is to show you that we want to expand and to greet in the society researchers, radiologists, and moving up the skeleton as well. So to you, Tom.
Yes, thank you, Francois. Thank you, Tanguy, as well, for setting the meeting up here, and also Francois for the idea of bringing OCTA research and the International Weight-Bearing CT Society together, because we do share many common goals. Just to give you a little bit of background about OCTA research, we convened together in 2019 in those pre-pandemic year. And that was at the International Workshop on Osteoarthritis Imaging. And we were lucky enough to have experts from all over the world show an interest in trying to promote the role of CT in osteoarthritis research. We currently stand at a membership of around 50. Look, this is a very niche application of CT and a niche area of research, but one where we feel that we have the opportunity to embrace a wide range of expertise, and both from the research and clinical world of osteoarthritis imaging. And in particular, OCTA research embraces multi-scale technology. Weight-bearing CT is one of the types of CT that we're interested in, and we also engage with everything from synchrotron beam CT to micro CT, quantitative CT, and clinical multi-detector helical CT. You name it, if it's computed tomography, we are looking to support and promote and get involved and engage people with it. And our mission really is to better understand and promote the use of CT in OA research. And likewise, we are recognizing, as I think we'll touch on this evening, the need to standardize imaging protocols around the application of CT. And of course, we also want to build a network just for like we are working. And it's great to see all people from around the world here today, a network from where we can cross-pollinate our ideas as we move forward. Membership is also free for us currently, and you can contact us simply at that email address. Next slide. Thank you, Tanguy. Just to give you some insight into our executive committee, that involves myself and Neil Segal, who's be talking in a moment, but we have representation from across the world, Canada, with Andy and Sarah, Mikko Finala from Finland, and Catherine Stock in Melbourne, and with a variety of cross-cutting imaging expertise. So we are all embracing, and we invite everyone to get in touch and join us and add to that expertise. So here we can see the program that we've got set up for this evening. We're going to start talking to Neil Segal in a moment, then Philip Hansen from Copenhagen in Denmark will be talking to us, and then Matthieu Ollivier from Marseille in France. And as Tanguy said at the beginning, please do keep your questions for the Q&A session. We'll give you that time at the end, but also pop them in the chat. We'll keep an eye out for that. And if we can do some back and forth around what's going on, that'll be fantastic, provided it doesn't distract you from the excellent talks we're going to have. So let's start with our first speaker for the evening. Dr. Neil Segal is the Dr. George Varghese Professor at the University of Kansas Medical Center in Kansas, USA, where he's also the Medical Director of Musculoskeletal Rehabilitation. Now, he has directed a clinical osteoarthritis research program for 17 years and is a pioneering expert in the validation of weight-bearing CT imaging and imaging analysis protocols at the knee. And totally in keeping with the spirit of our joint meeting today, Dr. Segal is both an academic affiliate member of the IWBCTS and also a founding member, and as you saw, Vice Chair of OCTA Research. So it's an enormous pleasure to invite Dr. Segal to talk as our first speaker this evening.
Thank you very much, Tom. I'll go ahead and share my screen. Are you able to see my screen now?
Yes, indeed.
Okay, good. Well, this is an immense pleasure being a member of both societies and being a strong believer in both societies. Then I'm so glad to be able to participate today. The work I'm presenting has been done with a number of collaborators, and in order to get everything into 15 minutes, I won't be listing all of the people who've contributed to each part of the research. However, at the bottom of many of the slides are the references, and I would be glad to provide those to anyone who has interest. A number of the studies that I'll talk about today were conducted ancillary to the multi-center osteoarthritis study, which is a US National Institutes on Aging funded longitudinal cohort of osteoarthritis. So, speaking of osteoarthritis, osteoarthritis is the most prevalent joint disorder affecting approximately 30 million Americans, approximately 13%, and afflicting people with pain, substantial mobility limitations, and costing approximately $128 billion in annual healthcare costs in our country. The knee is the most commonly affected weight-bearing joint, and risk of disability due to osteoarthritis is equal to that for cardiac disease and exceeds that for any other medical disorder in older adults. Unfortunately, there are gaps that exist in our ability to detect the disease, osteoarthritis, and this has limited potential to prevent or forestall this prevalent disease. The introduction of imaging biomarkers that would be more responsive to structural changes in the joint, as well as patient-reported outcomes, would help us to speed up therapeutic progress, as well as to monitor patients in clinic to see who has the disease and how therapies are working. So what exactly is osteoarthritis? We've heard of heart failure or liver failure or kidney failure. Osteoarthritis is essentially whole joint failure. Contrary to its moniker, osteo, meaning bone, osteoarthritis really affects the bone, cartilage, menisci, ligaments, tendons, fat pad, the nerves and muscles that surround a joint. The structures that have been highlighted in yellow here are structures in which weight-bearing CT may have a role in improving ability to detect the disease and monitor it in comparison with other imaging modalities. Radiographs capture an inherently 3D structure, joints, like the knee joint, in 2 dimensions. So positioning can have a really large impact. Radiographs are also relatively insensitive to detecting osteoarthritis, and the exact angle of knee flexion during and the beam tilt on a radiograph can affect how the joint appears and whether someone's diagnosed with the disease or not, or same for evaluating progression. In fact, approximately 50% of radiographs that are read as normal in people at risk for osteoarthritis are actually found to have cartilage loss when viewed on MRI. There's a high correlation with structural disease. For an adequate biomarker, we need to have a high correlation with structural disease. Weight-bearing CT imaging using a low-dose scanner can more validly reflect osteoarthritis disease activity, and therefore this is of great interest. Weight-bearing CT, as I think almost everyone attending today knows, enables weight-bearing 3D imaging that places physiologic stress on the cartilage and menisci. And for the knee, this is really important. It's essentially a stress test for the joint, and this is the position in which most patients have symptoms. There are many excellent studies of weight-bearing CT from around the world, but due to the limited time for presentation today, I'll focus on summarizing a portion of the studies which I've led. Those studies have involved scanning a little over 3,500 knees for diagnostic performance, looking at test, retest reliability, responsiveness, concurrent validity with both imaging and patient-reported outcomes, predictive validity for those outcomes as well, looking at the accuracy versus radiographic and MRI features, and recently looking at diagnostic value for meniscal extrusion and meniscal tears before and after repair. So what value can weight-bearing CT add? Well, whoops, I didn't mean to put that up yet. Unlike radiographs, where we have to optimize the beam angle, with 3D acquisition in a weight-bearing configuration, then beam angle is no longer an issue. We can do multiplanar reconstructions or view the scanned anatomy from any plane or angle that we'd like. It also helps with evaluating ACL tunnel positions and hardware evaluation for other surgeries, looking at chondrocalcinosis, which usually is not visible on radiographs, although with severe chondrocalcinosis, of course it is. Looking at meniscal extrusion, as well as looking at muscle mass around the joint. This is an example of 3D bony visualization of the knee joint structures. And as mentioned, we can do multiplanar reconstructions. These are in the 3 cardinal planes, but you can look from any angle once we've acquired the 3D data. We can also look at hardware in the multiplanar reconstruction just shown, as well as in this 3D reconstruction. We can evaluate the ACL surgeries, as well as the unicompartmental knee arthroplasty that this patient had. We can also evaluate meniscal extrusion. This is an example, and more information on this capability will be on subsequent slides. And then that other feature listed was looking at periarticular muscle mass, which we can look at each individual muscle and tendon around the joint with weight-bearing CT. And it actually appears different when we compare MRI, which is generally collected in a non-weight-bearing configuration, versus a weight-bearing configuration where the muscle forces are active. The first study that we conducted looked at the diagnostic performance of weight-bearing CT for some of the features that osteoarthritis is best known for, osteophytes and subchondral cysts. In comparison with radiographs depicted in yellow, weight-bearing CT demonstrated a higher sensitivity and accuracy for detecting both osteophytes and subchondral cysts. This was in comparison with an MRI reference standard. Of course, these particular features don't require weight bearing to evaluate, but since this is how osteoarthritis has frequently been diagnosed in the past with osteophytes, then it's a great opportunistic acquisition of these important features when weight-bearing CT may also be used for looking at joint space width, meniscal extrusion, or other features. A novel biomarker for looking at osteoarthritis is 3D joint space width. Joint space width, the distance between the tibia and the femur within the knee joint, it has been used for years on 2D radiographs, and porting that to 3D joint space width has taken some exploratory work that's been done by the group of Don Anderson in University of Iowa, as well as Tom Termazet, who of course, both of whom are on today. On this slide, you can see a heat map with the hotter colors showing smaller joint space width, for instance, 0 to 4 millimeters, versus the cooler colors showing a greater degree of joint space width at those locations on the joint. Also, some abbreviations you'll see on other slides, CMF being the central medial femur, and then down here we have the anterior medial tibia, central medial tibia, and posterior medial tibia, because we wanted to look in specific areas to test the 3D joint space width biomarker. In looking at 3D joint space width, the first important study to complete was to assess test-retest reliability. And this is composite reliability at baseline and 2 weeks later, where we brought patients back and we used a specific knee frame in order to hold the foot, tibia, knee, patella, thigh, and pelvis in position. We found very high test-retest reliability of the composite of repositioning the patient, resegmenting the anatomy, and then remeasuring the joint space width. The ICCs are depicted in red on this slide for the lateral and medial compartments respectively. And this is an example of one of the knees at baseline and 2-week scan. And as you may be able to appreciate, the heat map for the 3D joint space width over the joint was very, very similar at both of those acquisitions. Once we confirmed the test-retest reliability, we were interested in looking at the validity of this. So this validity study, we used articular cartilage morphology, evaluated on MRI as the reference standard, and looked at the percent of the joint surface on which the joint space width was less than 2.5 millimeters on weight-bearing CT. That measurement correlated much more highly, a Spearman correlation of 0.84, than radiographic minimum joint space width, or 2D joint space width, which was 0.66. This advance could enable valid stratification of patients by virtue of quickly and inexpensively characterizing OA features that are less evident on radiographs. It's great to have a reliable and valid method, but for a chronic disease like osteoarthritis, it's essential for a biomarker to be able to be sensitive to or responsive to change over time. In looking at responsiveness over a 24-month period, in comparison with 2D joint space width on radiographs, which had responsiveness can be measured with the standardized response mean, which is the mean change over that time period, divided by the standard deviation for the change over that time period. For radiographs, the standardized response means were -0.13 for the medial compartment and -0.15 for the lateral compartment. As you can see on the left and right portions of this slide, weight-bearing CT 3D joint space width was much more responsive to changes over 24 months. And this provides evidence that 3D joint space width based on weight-bearing CT is highly responsive to changes in the tibiofemoral joint. Now, as we started out explaining at the beginning, osteoarthritis affects multiple aspects of the joint. In this study, also conducted ancillary to the MOST study, we looked at meniscal extrusion on MRI and compared to meniscal extrusion on weight-bearing CT, and found that in meniscal extrusion was not detected on MRI in just under 36% of cases in which it was detected on weight-bearing CT. And weight-bearing CT had a greater degree or a greater score of medial meniscal extrusion in approximately 2/3 of cases compared with MRI. This is an example from that study. On the non-weight-bearing MRI seen in the leftmost panel, we don't see any meniscal extrusion or extrusion of the meniscus beyond the medial and lateral tibial margins, whereas on the weight-bearing CT in both smooth and sharp coronal reconstructions, we can see extrusion of the meniscus beyond the joint margin, over here and over here on your screens. The next area that we began to study was putting contrast in the joint. Seeing meniscal extrusion is very important for osteoarthritis, but meniscal tears are also a contributor to osteoarthritis of the knee as well as an effect. In looking at weight-bearing CT arthrography, in follow-up to our non-contrast study of weight-bearing CT for visualizing meniscal extrusion, we found that contrast enhancement showed a significant number of meniscal tears that were not detected on MRI. In the yellow column central to the slide, for tears in the anterior horn, body, and posterior horn of the medial meniscus, we see between 28 and 44% of meniscal tears in which on weight-bearing CT arthrography, the contrast penetrated all the way through the meniscus. Then meniscal tears were not evident on the MRI in those scans. Here is an example from that study in which we see a horizontal tear of the posterior horn of the medial meniscus opening to the inferior surface and the posterior base. On the corresponding MRI, we see just non-specific signal in that area, which wouldn't meet criteria for diagnosis of a tear. This is an example of how contrast appears in the joint and very nicely highlights the cartilage, meniscus, ACL, PCL, and other soft tissues within the joint. All of these features we talked about so far were for the tibiofemoral joint. And of course, the knee contains the patellofemoral joint, which is very important, especially because osteoarthritis of the knee frequently starts in the patellofemoral joint, even before it progresses to the tibiofemoral joint. In this study, we looked at radiographs and weight-bearing CT read for Osteoarthritis Research Society International Joint Space Narrowing Score, and MRI, which was the reference standard for the study, was read for MOCS, which is a semi-quantitative measurement of cartilage loss. The sensitivity and accuracy of weight-bearing CT was significantly higher than for radiographs for both outcomes in the medial and lateral compartments. And we can see weight-bearing CT and radiographs, weight-bearing CT being in blue on your slide, in comparison with the sensitivity and accuracy of radiographs. An example from this study is here, and I have my concluding slide after this. In the right portion of the slide, we can see that bone superimposition is somewhat problematic in seeing the osteoarthritis of the patellofemoral joint on radiograph, whereas in the left upper panel, we can see that the severity of osteoarthritis in the medial patellofemoral joint is much more easy to appreciate on weight-bearing CT and actually shows a greater severity, bone-on-bone severity on weight-bearing CT, whereas non-weight-bearing MRI could potentially underestimate the degree of damage in cartilage. In conclusion, the clinical relevance of this is that Weight-bearing CT offers better diagnostic performance for both tibiofemoral and patellofemoral osteoarthritis than radiographs without significantly increasing radiation dose. 3D joint space width as an imaging biomarker corresponds with the presence and severity of central medial tibiofemoral cartilage loss. And this provides greater information about the distribution of tibiofemoral joint space width while maintaining high reliability and responsiveness over time. We've also found it's more sensitive to meniscal extrusion and meniscal tears than MRI. And the greater responsiveness to change as well could allow clinical trials to be a shorter duration and more affordable, which could really hasten the pace of scientific discovery. So 3D joint space width on weight-bearing CT, it appears would allow more rapid assessment of therapies, and this could help us in clinic to both diagnose as well as to follow the effectiveness of therapies that we're prescribing. In our recent work being conducted both in Dr. Anderson and Dr. Termazé's groups, then there's been automation of the segmentation of these so that 3D joint space width will be an even more convenient measure than in the past. I'd like to thank both groups for sponsoring this session today and recognize the National Institutes of Health for supporting the MOST study, in which many of these ancillary studies were conducted, and thank the staff and participants, as well as thank CurveBeam for providing the weight-bearing CT scanner used for many of the studies presented today without stipulations regarding its use.
That's fantastic. Thank you so much, Neil, for showing your vast expertise in this area and sharing your work on such a wide range of applications that demonstrate not just the versatility, but the unique capabilities that the weight-bearing CT has in the field of osteoarthritis. So what I'm going to do in the interest of time is we're going to move straight on to our next speaker, and any questions, please put them in the chat and we can take them forwards towards the end. So our next speaker is Dr. Philip Hansen, who has a background actually as a sports physician, but currently works as a consultant musculoskeletal radiologist at the Bispebjerg Frederiksberg Hospital in Copenhagen in Denmark, and also as an associate professor at the Department of Health Sciences at the University of Copenhagen. Now, there's a long-standing expertise in weight-bearing imaging within the musculoskeletal imaging research unit at their Department of Radiology, with Dr. Hansen focusing his research on weight-bearing imaging at the foot and knee, with a particular interest in the assessment of positioning and measurement reproducibility in these areas. So, without further ado, it's a huge pleasure to invite Dr. Hansen to present as our second speaker of the event.
Thank you very much, Tom. Can everyone hear me? Okay, thanks. And I'm very pleased to be invited to give a talk here. I'm afraid that it might not be quite as focused on osteoarthritis, and we'll more go into detail about some of the reproducibility issues. We heard Neil talk a little bit about this, and I will present some problems and maybe not give any conclusive solutions to the problems, but highlight that there are certain things that we need to address when we go into the world of weight-bearing cross-sectional imaging, and not least the weight-bearing CT. So the talk here is going to focus on patellar instability, and of course with emphasis on weight-bearing CT and the quantification of different anatomical predisposing factors in patellar instability, namely the trochlear dysplasia and what's called the TTTG distance, which is one of the important measurements we perform when evaluating this the instability, and then briefly about patellar alta. And I'll try to demonstrate some sources of variation that can occur when you do measurements with the weight-bearing CT. And yeah, and highlight again that I think we need to optimize repeatability and join forces to be better at reaching a high level of repeatability. So the patellar instability is this constitutes different severities. So the most severe is the so-called objective patellar instability, according to the Lyon school, and that's when you have a true dislocation and one or more anatomical abnormalities by radiology. Then are the milder forms of potential patellar instability, which is more subjective symptoms and not overt lateral dislocation. And we all know the patellar pain syndrome, which is highly prevalent, but which typically does not present many morphological abnormalities by imaging. So, but this is a case of OPI, or severe patellar instability. I'm sorry that it's not weight-bearing CT, but this is from a weight-bearing MRI unit. So, and just briefly about the epidemiology, there's a quite high risk among young people, 29 per 100,000 for the first time patellar dislocation, and it constitutes 2 to 3% of all knee injuries, and it's very prevalent. It's often occurring during sporting activities. And if you're young and you have your first patellar dislocation, there's a very high risk that you have your another re-dislocation at a later point. So this is important. And girls are at a higher level of risk than boys. And the problem, and this is focusing us on the osteoarthritis, is that we know that just from having your first time lateral patellar dislocation, you will have some level of cartilage injury. And if we don't pick up on this and try to do some preventive measures, the end stage might be severe with patellofemoral osteoarthritis and maybe the need for a prosthesis in an older age. And since these are young people, I think we have an obligation to try and become better at detecting the underlying anatomical abnormalities. This is a typical case. In the ER non-contact, it doesn't have to involve very high levels of contact during sport. And of course, many of you have noted that there was joint infusion, and we zoom in, we can see some subtle bony avulsion on the medial patella and a loose articular body. And we often do MRI, and it often is quite a severe injury when we do both MRI and CT. For instance, an impaction fracture is not infrequent in the lateral side of the lateral femoral condyle from a kissing lesion from the patella. Of course, we have some MPFL discontinuity, and often we see a chondral fracture, hemarthrosis, and then importantly we see a flattened trochlea. And just to briefly highlight how you should pick up on this on the basic X-rays in the ER. Please note one of the very important lines to follow is the deep part of the trochlea, the blue line, and this great illustration from Rat Source. There's a great article on the website there. That should always be below the outer portions of the femoral condyles. So if it reaches one of the condyles, there's something wrong here. Then you have some sort of trochlear dysplasia. That's the hallmark. It's crossing sign. All the de jure types that we have, they contain the crossing sign, and then you can look at the finer details. But please look at the crossing sign first. And why is it important with the imaging in trochlear dysplasia patients, and why do I stress that we should have a high level of repeatability and precise measurements? Well, the surgeons are using the radiological measurements to guide their procedures. If you have a severe instability, you may be scheduled for a sulcus deepening trochleoplasty. and what you can call a la carte surgery. You might be transposing the tibial tuberosity to adjust the force vectors acting on the patellofemoral joint, and these measurements are crucial in that term. And just going back to the trauma case, you may not have noticed, but there was a crossing sign. So again, a telltale sign that this was a dysplasia patient that had a lateral dislocation. So, but of course, we need to quantify these anatomical factors. And regarding the lateral patellar dislocation, there are 4 factors, anatomical factors or risk factors that have been identified by the de Jure group. So the trochlear dysplasia is very important. And then we have a patellar tilt angle above 20 degrees, patellar alta, and then the abnormal TTG distance. And these matters can be quantified by our imaging, but we need to be sure that this is performed very precisely. And multiple factors can go into producing measurement variation bias. For one thing, we have the choice of anatomical landmarks. And in this sense, I'm thinking about cartilaginous contours versus osseous, of course, MRI versus CT. And in the basic form, we will, of course, measure the osseous contours by weight-bearing CT, but as Neil just told, if we add contrast, we might be able to also measure the chondral contours in a better way. We have the issue of non-weight bearing and weight bearing, and by introducing weight bearing in a 3D technique, we certainly increase the variation or the potential for variation in our measurements. So we need to address how do you move from the 2D space to the 3D space, and when we add weight bearing. Then there is a simple matter of knee flexion angle, which I'll try to show. We need to address how do we position our patients and how do we orient our imaging planes, and which planes on our images are we choosing to do the measurement from. So, and just to sort of touch on the difference between the conventional CT and the weight bearing, and the effect of weight bearing in itself. There's been some studies, initial studies, nice studies by Hirschman and Matthieu et al. Particularly Matthieu and al. Have shown that there are quite some differences between conventional unloaded CT and weight-bearing CT. And you could see, for instance, the tilt angle here, the congruence angle, and the TTG offset, and compare with conventional CT. There are quite marked differences here. But they've tried to tease out the sort of the effect of weight bearing in itself, and that seems to be about, on the TTG distance, about 3 millimeters in full extension, and about 2 millimeters in 30 degrees of flexion just by weight bearing itself. So they might push sort of the patient below or above some arbitrary limits there. So the solution to this is likely to be that we need some kind of monitoring of the load that goes into the joint, and for repeatability, that we ensure that if we are following up on a patient, we are inducing the same load on the joint. As mentioned, the TTG distance is also a crucial marker. It's a sort of a pseudo Q angle measurement on images, and the Q angle is, of course, sort of a clinical measurement to evaluate the force vectors acting on the patella to move it laterally, and the greater the angle, the more the force there is on the patella to go laterally. And the TTG is, for those that might not know it, you draw a tangent that intersects the posterior condyles of the femur, and then you have a perpendicular line going through the center of the trochlear femoris, and then you measure the perpendicular distance to the center of the tibial tuberosity, and this should be below 20 millimeters, or if it's above, it's regarded as being absolutely pathological. But if it's between 15 and 20 millimeters, it's in the gray area. What we should be very aware of is the degree of knee flexion when we do our TTD measurements. If you have a sort of a slightly past middle-aged male who he thinks he's still 20 years and has a 20-year-old joint, when I go into the scanner, I can measure in the gray zone area, 17.5 millimeters. I don't have any subjective knee problems. But look what happens. This is in the sort of hyperextended position that I like to stand in when I'm feeling comfortable. But when I'm asked to go into 20 degrees of flexion, something happens. My TTD distance, it normalizes completely and goes down to about 3 or 4 millimeters. So we should be very aware of the flexion in the knee. This is not surprising. There are good studies out there, for instance, by Hirschman, who examined multiple flexion angles and found for the TTD there was quite some differences in the distance there. So this needs to be monitored, and one solution could be to have a goniometer with real-time feedback during the scan to ensure that you are indeed maintaining the correct position during the scanning. We have tried this, and we're working on this with my PhD student Sine, so who's working heavily into the repeatability here. And it seems that you can maintain a 20-degree flexion during the duration of the scan without great problems. So I'm hopeful that this might be a good solution. Then there is the imaging plane, or positioning of the patient. And just to give you an idea here, I've tried to manipulate by the MPR module the sort of the alignment of the longitudinal axis of the femur and the tibia relative to the sagittal plane, which you can see in the lower panels. And in the upper, I've tried to illustrate what happens to the TTD distance just by manipulating the plane angles. And it's pretty obvious that there is a correlation here, and it has been our data has shown around 1 millimeters per degree of abduction or adduction in this term. So we really need to address this issue and come up with a nice solution how to normal or standardize the imaging planes, and I think it should be a method that's useful in daily clinic and not too advanced. So we are working on this at my facility currently. Then the image plane selection. How do we, in a 3D data set with multiple slices, how do we determine where do we measure, for instance, the center of the trochlea? And this is not without influence on the TTD distance, for instance. So there's one study by Yin et al. That shows that the lower you go, the more the center of the trochlea shifts. It's about 2 to 3 millimeters going from sort of the entrance of the upper trochlea and going in the caudal direction. So this should also be highly standardized. And they show that the interval between 6 and 9 millimeters below the trochlear entrance was maybe the optimal point to do your measurements. So, and then lastly, about the patella height, this was originally developed for conventional radiography in 2D, and now we would like to look at it in 3D and combine it with weight bearing. And it's been shown that it's slightly sensitive to weight bearing, some of these variables, but that we can take into account. But again, we need to take into account the imaging planes here. So I've again tried to manipulate the planes, and it's pretty obvious that if you in the coronal slice here, again taking the longitudinal axis of the femur and the tibia and manipulate it relative to the sagittal plane, you can hit different anatomical landmarks on the patella. And you can also move medially and laterally on the coronal sections, and you will have a markedly different shape on the patella there. So again, something that we need to address. So the take-home messages, I would say, was of course we need to precisely quantify anatomical predisposing factors in patella instability, and with the introduction of weight bearing in a 3D environment, we have the risk of introducing a greater level of variation, and we need repeatability, test repeatability to have that in place, and also our measurements protocols should be highly standardized. So my invitation would be to join efforts across the globe actually, and see how can we come up with a consensus on how to do this in a way that we can share information and data across the world, so and not have bias that is sort of hampering our knowledge. So by this, I will conclude my talk, and thank you for your nice attention.
Thank you so much, Philippe. It's great talk, and we'll come back to it later with the questions. Now, it's my pleasure and honor to introduce Matthieu Ollivier, who is a professor of orthopedics in Marseille. So that's down south in France. A very, very nice city, a very nice seaside. Professor Ollivier is a very active researcher and publisher. He is called Lucky Luke in France because he never misses his HTO osteotomies. And he's also my PhD thesis professor. So he's overviewing my own work. So I'm humbled to have him tonight. I have to say that he's recently joined the Weight-Bearing CT Society as the knee representative. So we've asked him to be very active and to promote our society. And well, he's showing a lot of dedication with this talk tonight. So thank you, and the floor is to you.
Thank you, Francois. Very happy to be with you tonight. It's two societies, I guess, that will make research and make potentially clinical practices in the next years. I'm really happy to be involved in the Weight-Bearing CT Society, because I do think that in my specific expertise, which is more or less lower limb alignment and ACLs and sports medicine in general, it will have a deep impact on the way we are doing research and clinical outcome and clinical research project, and how we treat patients in our daily lives. But tonight I select to talk a little bit about one of the pioneer in surgery. It's called Johan Mikulic, and it's always good to remember what was done by those guys at the time. Now we are talking about 3D weight-bearing CT scans, and what was done when the guys only had these bare hands to dissect tons of cadavers to imagine what was morphometrics, human beings, and how we should correct and assess abnormality in lower limb alignments. So Johan, I spent some years in Mayo Clinic when I was a fellow, and the Mayo brothers named him the Prince of the Surgeon. You need to remember that it was in the 1850s. 1850s. He died in 1905. So it's pretty old, but let's imagine that it really changed the way we are imagining surgery today. And let's get into business with his medical thesis, which is the more orthopedic part of his life. He examined more than 100 specimens, dissect knees, tibias, and femur before any X-ray era, because Rodden will design the X-rays like 25 years after his medical thesis. And he was the first to define clearly how lower limbs are supposed to be aligned, how femur and tibia looks like. He done tons of drawings and specifically defined what was the Mikulic line. And when you do lower limb alignment and specifically osteotomies, Mikulicz is a name that's come in any discussion when what is supposed to be the Mikulicz line, where is supposed to pass the Mikulicz line on the joint. So to be honest, this is the Mikulicz line we have. It's completely fold, because at that time when in the medical thesis paper were fold, and the only PDF version of the thesis we have is completely fold. So I mean, you don't understand nothing. And it took me 5 years with my friend Christian Clay to find another version of the thesis, and we finally find out that this is the actual Mikulicz line. It's something that is not existing today, because only us have this medical thesis in our houses now. There is 4 versions available still of this medical thesis. So this is what the Mikulicz line is supposed to be. And this guy, without any X-ray, imagine that there was a connecting line from the center of the femoral head to the center of the knee to the center of the ankle. You can call that the weight-bearing line. It's not so easy to imagine when you don't have any way to image people and to have global vision of what the lower limb is supposed to be, how the lower limb alignment is produced by femoral alignment, intra-articular alignment, and tibial alignment. Some 2 centuries ago, this guy in Poland, in the middle of, let's say, middle of nowhere, without any budget, without any sponsorship, without any grants, dissect himself tons of cadavers to analyze what was the lower limb deformity. And today, to be honest, we are all every day talking about his outstanding research. Because when we do osteotomies, we all draw this line to begin, and this is the long axis X-ray. Don't worry, we get into 3D and CT scans and weight-bearing CT scan when the talk is going. So whenever we want to discuss about alignment, we draw this line. If this line is passing inside of the tibia and the femur, it's a varus knee. If it's outside, it's the valgus knee. So this is the point 1. And then the projection of this line onto the major lateral femur is the basics of any lower limb deformity correction and any lower limb deformity surgeon. The projection of this line on the major lateral compartment of the tibia and the femur, we call that the Fujisawa point, because it was defined by this Japanese doctor in the late 80s of the last century. So Fujisawa defined that the best spot to target when you correct the lower limb alignment was somewhere in between. So he defined this in percent based on the global length of the upper tibia. Defined that the ideal position of this Mikulicz line after the surgery was around 60 to 70%. It is something that the TKAs, UKAs, and intra-articular implants globally didn't exist. So they were treating patients with the very bad conditions with the only thing they had into their hands, which was cutting bones and trying to realign the lower limb axis. So it changed a lot thanks to American researcher, Doug Delanois, that probably are the pioneer of osteotomies in the early 2000 century, the 2000 millennium. And they select that potentially the best way to correct axis was not to get so much into this lateral compartment, but still stick in the middle. Today, some 21 years after, we are more or less trying to focus on what we call the 55% Fujisawa line. And this is how we get into 3D CTs. It seems that this first 55% get an easy clinical and accessible way to be spot. It is the lateral spine of the knee. So when you analyze in any kind of at knees based on 3D CT weight-bearing CT scans, you will see that this lateral spine is always spotted at 55%, which seems to be the best spot when you want to correct a varus into a valgus knee, specifically in knee osteotomies. So this is how we convert this Mikulicz work of where it's supposed to pass the Mikulicz line based on his medical thesis into something that we can assess in 3D weight bearing, actually, where it's supposed to pass this line when you correct the lower limb alignment. So it took only 300 years to improve our understanding on that. And thanks to 3D models and 3D weight bearing CT scan, now we are focusing on 3D position of this Fujisawa point of the Mikulicz line. And you can see here that our vision of where it's supposed to pass the weight-bearing line after any kind of surgery to protect the knee from arthritis is moving forward. And now we are discussing this position in 3D. Specifically, when you, of course, when you have access to this kind of high-rise imaging, you can more or less decide exactly the spot where when you want to modify the position of the weight-bearing line, doing osteotomies, doing implants, doing TKAs, UKAs, any kind of realigning surgery would be deeply impacted by this kind of analysis. And what is this important? What those philosophical issue? Because when we focus on every osteotomy performed in France in the last 5 years, we discovered that it was performed in the wrong bone in more than 50% of the cases. This is kind of a series that are not very satisfactory for surgeons, because we just discovered that we make it wrong in 50% of the cases, which is not very good. Once again, returning to Mikulicz line, we draw this line, we analyze where is supposed to, what is supposed to be the angles. This is a double level osteotomy I performed some years ago. The good question is, what is the good correction on that, and why do we have discrepancies in between static X-rays, weight-bearing X-rays? And the reason is very easy to understand. The main difference, if you only focus on what is moving in between morphologies of the lower limb between weight-bearing and non-weight-bearing images, is what we call GLCA, the joint line convergence angle. And it's the worst part of any surgery, because it's something we don't know. We don't really know when doing surgery how the weight-bearing line will react in terms of weight-bearing shifting, in terms of intra-articular reaction. This is something that is almost impossible to imagine. So there is some equation, there is some algorithm to trying to, let's say, nullify the impact of this intra-articular wear inside of any realignment surgery. And you can see here that you have a nice example of this patient which has a pretty big intra-articular varus, and you will see this is stress X-ray from varus to valgus. The joint line convergence angle, so the line connecting the distal condyle line, the distal condyle position to the proximal tibial position, is completely shifting from varus to valgus, and this is the part we don't get when we are inside of the OR, because we don't have weight-bearing patients. When we operate them, they are sleeping supine on the table. So this is something we need to imagine. And I do think that there is a huge room for weight-bearing CT scan on this specific area, because of that, and because of the analysis we will do of this intra-articular wear, it will be better tomorrow to imagine what will happen when we do surgery on this kind of patient. Morphometrics, once again, Mikulicz did something else in this medical activity, just of course defines Mikulicz line, but also define what is normal inside of human beings. And some 250 years ago, before Joel Pally, which published let's say the most known books on the subject, he already said that the medial plateau tibial axis, which is the reference angle we analyze when we do tibial osteotomy, was around 85 to 89, and the femoral the femoral mechanical axis was around 82 to 90. To be honest, this guy just with his bare hands and goniometers shoot exactly the good angles, because we do the same with weight-bearing CT scan. We published this in case study 1 year ago, and it was exactly the same result with modern images. So this pure genius with his hands, with the goniometers, analyze hundreds of femur and hundreds of tibia. We do the same with thousands. And to be honest, he was right, totally right. He was exactly in the range we can find in normal human beings. This is really important, because knowing the normal is the basics to correct the abnormal. So this concept of weight-bearing line, if you imagine that, he was the first to say that we have a small amount of varus in the tibia and a small amount of valgus in the femur, which is now the number one rules when you do a total knee arthroplasty. When you do any compartmental knee arthroplasty, or you do an osteotomy, it is something we want to create, or we want to return back as it's defined to be normal for more than 300 years now. And this is an example of patient. Once again, we do the first thing we do when we do osteotomy, we measure the abnormality of the angles, and when you look at these angles, in these specific cases, the abnormality is on the tibia. What is the ideal correction? When you know what is abnormal, you can define what is normal. And once again, nowadays we are helped because of this kind of, we call that the wizard. So it's a specific software that helps us to analyze deformity. There is no nothing left than putting some points. So the result help you to define what are the points to put to have a deformity analysis. When the point are points, the software tell you what is normal and what is abnormal by red and green lights, as you can see here. And then you just decide what you want to do. For example, here, advise me against distal femoral osteotomy and recommend high tibial osteotomy. So I just have to draw the line I want to decide the cut I want to realize on this tibia, and decide where I want to have a weight-bearing line at the end. Let's imagine something about 60%, and the software is defining itself the surgery I need to perform. This helped me to have a very good hands and a very good brain, because when you know what to do, it's easier when you get into the OR to have everything defined already, to be prepared for everything. And once again, as this joint line convergent Segal is a full weight-bearing parameters, you get an example here. It's only 2D images, but you can imagine how it will react in 3D. So you have, for example, all the measurement for these legs in a bipedal stance. Same thing for the left one. Now it's monopedal stance, so you can see that the angle changed a little bit, but which angle is changing? Of course, the joint line congruency angle, which is the second one here, that was green at this step, and now is becoming red. Same thing for the right one. And if you look on the CT scans with non-weight bearing, you can see also that this angle is completely changing with a complete normal angle at this step. So once again, the future of any lower limb analysis and lower limb deformity surgeon is to analyze 3D weight bearings images, because it's changing everything in terms of what we are able to do in OR, and specifically what will have patient when they restart walking on legs, because everything we do is a static supine position surgery when the real life is more or less standing and walking. Last part of Nicolas' work, torsion. So I heard the talk of Peter. He was talking about TTGT and things like that. It's also a very nice thing to analyze torsion when you have patellofemoral disorders, because TTGT is just a repercussion of that, and the abnormal TTGT usually came from a massive external torsion of the tibia. And Mikulic already did that. Once again, it's a 3D rotational plane, so it's even worse to imagine when you just have a bone on a table. But he defined that the normal anteversion of the femur was 20 degrees. Normal torsion of the femur was 27 degrees. And we have exactly the same analysis in our 3D CT database. To be honest, we were smashed to see that this guy with only 100 bones complete deformity of the bones. We exactly have the same thing for anteversion and tibial torsion 300 years after, with hundreds and thousands of CT scans in our database. To be honest, it's very impossible to define torsion with only your eyes and bare hands, but it did it. And to be honest, you need to be applauded for that. And this is the reason of my talk. 3D rotation implies weight-bearing analysis for a reason which is simple. It's almost impossible to standardize the position of the bone on 2D plans when you have, for example, X-rays. And as long as you have 3D images, the torsional aspect of the bone is imaged by itself. So you see how the bone are turning around from a joint to a joint. And this is also one of, I think, the biggest part and biggest blank space in the actual imaging facilities we have, specifically connected to weight-bearing CT. Some last word on Jan Mikulic, because it's not only that. He spoke 5 languages. He was the piano for rehearsal for Brahms in his country. I'm not playing piano, but I guess playing for Brahms was not bad at this time. He published in 4 different languages, and his name is found everywhere when you look to the early 19th centuries and early 20th centuries surgical specialty, Euro, OB, orthopedics. He is everywhere. He diagnosed his own stomach cancer, but refused to be operated on, and died and do surgery even 3 days before his death. Thank you for attention, guys.
Thank you so much, Professor Ollivier. Now, I will give the floor back to Tom in order to summarize the content we've seen, and then start the Q&A.
Well, yep. Thank you, Francois, and thank you to all of our speakers. I think what we've struck here from some conversations I've been having with individuals, that we've got some fantastically important issues that weight-bearing CT is presenting with us because of the luxury of the 3D information that it can afford us in functional positioning. And this is, as Matthieu's talk showed us, this is embracing orthopedic issues that have historically been known about and recognized, and we're taking it to a next level. And when we take it to that next level with the breadth and the versatility of the weight-bearing CT modality, we have to be sensible and careful to understand what ranges we are working, what are limits we are working in with respect to reliability, whether that's at the patellofemoral joint and instability, as Philip has highlighted for us, or some of the other measures such as joint space width that Philip brought to us. But I think what we definitely are sensing here, and is what's great to see in terms of the different background of individuals we have, not just from our speakers, but attendees ranging from orthopods to rehabilitation. We should be considering pain specialists. And also I can see several AI experts and information analysts on the call today, and they will have a huge role, because there's the software that Matthieu showed us in terms of alignment. These are the other people we need to work with and work together with on developing what we can then recognize as robust and valid tools in the context of the 3D constructs that weight-bearing CT is bringing to us. So we can definitely identify protocol standardization is a key issue. And also we need to start thinking about the availability and installation of these, because part of what today is about, again, from the platform and from our 3 Excellence talks, is making this technology available and known, and that will involve getting these kinds of units into research and clinical environments. So what we should do is we should start with some questions, and I think it's only fair to go back to one of the earlier questions from Claudio, which maybe I can put to Matthieu, which was, he was asking about, do you think that, Claudio Belvedere, this was, do you think that ACL reconstruction, patellar tendon surgery, or PFL reconstruction, patellofemoral ligament reconstruction could also benefit from this technique, since the surgeon might be more aware of the prop and tightening condition the reconstructed ligament must be subjected to? And that's to Matthieu, just wondering from your orthopedic standpoint.
Sorry, I was muted. But okay, yes, and yes. No, I'm kidding. No, I guess. I mean, we are working with Francois nowadays on softwares to that was showed of the articular joint space. To be honest, ACL is a major candidate for weight-bearing CT prior of the surgery, because I think that we'll be able to measure the anterior drawers that occur in ACL deficient knees on those images. And second, I do think that we'll be able to analyze quantitative the differences in between pre-op to post-op in this kind of images. Because once again, the question is, what will be the future of this patient when returning back to sports? What you feel with your hands when you do anterior drawers and rotation laxity testing is like, I will not say bullshit, because it's really meaningful for and clinical relevant for orthopedic surgeons, because we know how to do that. But we have patients with perfect knees that act perfectly normal into the OR and in the post-op regimen, and after 2 matches they return the ACL in a rotatory pivot shift that occur, we don't know why. So those guys will, of course, be big candidates for 3D weight-bearing analysis, because I do think we will analyze something new, which is the position in between the femur and the tibia when weight-bearing.
Excellent, thank you, Matthieu. And Claudio, I hope that gives you some answer to your question. Is there anyone that would like to be unmuted to ask a question? I have some ideas, but I would love to engage.
Can I be unmuted to ask a question?
Francois, you would like to be unmuted?
Yes,
I think we can allow
I
that,
unmuted myself.
Okay.
Okay, I just want to say hello to Claudio. everyone, most of you know Claudio. He's from Rizzoli Istituto in Italy. It's a prestigious institute, and this is just to say that there is a lot of very clever people here tonight. And I just wanted to state that we've had 110 registered, and at the highest we had 64 participants. That's over 50%. I've never seen that. So that means that we have a lot of dedicated people, and I've seen from the comments that everybody is a fan of the technologies. Just want to state that it's more like being fans, like we should advocate for the technology, because we are all convinced that we should just replace radiographs by weight-bearing CT. We should advocate this. This is another way for us to serve our patients. I just wanted to ask Neil Segal and Chris. I think Chris asked a question, but privately to Neil, and Neil answered everybody. That was the 8:36 p.m. Answer. So Neil, could you tell us a bit more on what was that question? Because the answer looked interesting.
Oh, I didn't realize he'd asked me privately. And then I actually sent the answer to Tom and thought, oh, I wasn't supposed to send to Tom. So
no, you sent it to everyone.
Well, no, I
got it privately
after I sent it to Tom. Yeah. So let's see what Chris had asked. I remember the spirit of it. I'm trying to scroll up. There are a lot of comments since then. Well, basically what he did is he said, well, you don't see cartilage on the X-ray, was his question. And I wasn't sure if he was responding to a particular slide or study. And so I responded to him, yes, of course, I agree. You don't see cartilage on X-ray. And that's why joint space width is used as a surrogate measure. And because that's a commonly used surrogate measure on radiographs, we compared joint space width on radiographs to MRI and joint space width on weight-bearing CT to MRI. And in both patellofemoral and tibiofemoral compartments, we found that joint space width on weight-bearing CT was significantly better correlated with MRI than was radiographs. So that's how I responded, but his question wasn't completely clear.
Sorry for this, Neil.
Sorry, Chris.
Sorry for everybody, and thanks for getting me unmuted. The question was more related what we get as questions. I'm arguing a little bit from an industry perspective, not only diagnostic perspective, and Tom alluded to. We need, I think, to go ahead with making weight-bearing CT more implemented in clinical trials also in this. Tom, you are nodding. We have talked about this. I think it was last in PI at one of the imaging workshops. Neil, my question was more related. You don't see the cartilage in the CT. Okay, be my guest. MRI maybe sees the cartilage, but does not see the subtle changes in the bone. So we have two ways of imaging modalities that could be complementary, in my view. That was a little bit the background of my question. They could be complementary in terms of a full diagnostic. And today in this webinar, we heard the different aspects in this, especially focusing on weight-bearing CT, okay. But what would be the complementary role of weight-bearing CT to MRI in the whole thing? That was a little bit the background. Neil, I put you on the spot. I was not aware that it was not, I think it was not privately, everybody could see it, but that was the background here for explanation.
Yeah, Chris, I appreciate you attending and bringing that up. I do think that MRI and weight-bearing CT are complementary tools, just like we have screwdrivers and hammers in our toolkit. We want the right tool for the right job. And looking at inflammation, synovial hypertrophy, fat pads in the knee, physiology of the cartilage. MRI can contribute so much for that sort of imaging. However, for looking at meniscal tears or looking at osteophytes or subchondral cysts, then weight-bearing CT contributes a lot for that. And so I think they can be used complementary, and they can also be like for surgical use, we can co-localize by registering the weight-bearing CT to the MRI to put the MR in a weight-bearing configuration.
Well, absolutely agreed, Neil. As a patient, I'm coming also from this angle. You take an X-ray and you take an MRI, and the two of them are not really talking to each other. What I think should be the future should be a weight-bearing CT and an MRI, and then you can draw diagnostic-wise. And I'm putting now my head on industry-wise, also an inclusion criteria in clinical trials, and come to better inclusion criteria. That's my thinking.
I agree.
Philip, have you got?
Yeah, I have a small comment, if I may. We do have a few systems with weight-bearing MRI, so I could see that you could perhaps combine these and have even further information on the soft tissues, on the cartilage and the menisci and so forth. So, but without any doubt, my experience is that it's more difficult to do the MRI, and that is of course based on the fact that you have to stand very still in the MRI scanner to have useful images, and that might be a problem if you have a painful joint, and especially if you need flexion on the joint, for instance on the knee, and have sustained the flexion for like 2 or 3 minutes perhaps. But I do see some complementary possibilities between these two techniques also.
If I may, thank you very much, Philip. If I may come in as well, I had some back and forth as we were promoting the event, and there was some response to a thread on LinkedIn, Philip, in which you were involved. There was an imaging technologist that felt quite upset that maybe there was some castigation or something negative about the ability of imaging technologists and radiographers to take weight-bearing imaging according to the correct protocol. And I was quite careful to respond that is a really important skill, and that is a highly valued professional skill. But we've got a new level of information that we are achieving with the 3D imaging approach. And that also again brings in our analysis and AI experts in terms of, I certainly know at the foot and the ankle that there have been suites developed for landmarking on the back of segmentation, and a recent paper saying, look, these are more accurate, but they are measuring different things, and it's our job to move forwards and understand what those are in the context of clinical trials and clinical practice.
So, if I may pick it up from here, I think that, we're touching at the center of what should be our main focus. At OCTA and Weight-Bearing CT Society and working together, it's this standardization idea, because it's 3D weight-bearing CT is like a whole new world. There's at least one more dimension. We've talked about possible dynamic examinations as well in patellar instability, but we have at least one more dimension. And that means that the information is not squared like in 2 dimensions, it's cubed. So there's this huge amount of new information to harness and to understand and to standardize. So it's very difficult to do. And I had a question about this for Professor Segal regarding joint space width, JSW. So we've been working the foot and ankle on distance mapping, which was described by Professor Segal from Drexel University in Philadelphia. Basically it looks like it's the same thing, but the protocols, the maths that you do to obtain the pictures vary slightly, and that might have some clinical or diagnostic consequences. So don't you think that even down to hardcore maths, that we have to get together and keep our eyes on what, you know, computer scientists are doing, and tell them what we're looking for, because we're at the verge of, you know, it's like everything else in society today, where computers and computer scientists are taking over. And we need to keep our eyes on what they're doing, and we need to be at the origin. We need to be the driving force behind this new technology. We must not just, you know, receive what computer scientists give us. We have to tell them what we want to see. So I think that we're going to talk about in the coming months or years about, for example, the Mikulicz-9, which I think was a very nice summary of the two previous talks. Like, how do we 3D-ize the Mikulicz-9 and the I've been learning lots of new words and names tonight. Fujisawa point. So how do we 3D-ize these landmarks? And there was another question here that I've been reading by, oops, I lost it, one of the last questions, by Sharmila Shatani. And she's talking about cartilage. She thinks cartilage is more related to clinics than bone. So why keep on using bony landmarks? I mean, that's an entirely interesting question. Why not use distance mapping or JSW instead of bony markers? You know, what is the next generation 3D or 4D Mikulicz line or Fujisawa point? So anyway, I'm saying a lot of things, but what I'm saying is, like, this huge new world is appearing in front of us, and we've got to get together and make something of it. And I think time is running fast, because computer scientists, that they don't have patients to look after all day long. They don't have patients to operate on. That's all they have to do, being creative and inventing new ways to measure things and doing maths. So I really want to stress that this is our role, and we should be interested. We should be interested in maths and physics and how to turn this great tool into something that is clinically relevant. And
I should just say, Francois, it's great to see. As I said, I think I can see at least 3 analysts and computer scientists that have joined to gain that understanding of where we would like to go, what the demand is, what the clinical need is for that. So I think, you know, it is good to see that engagement across all disciplines.
Well, that gives us a lot of idea. You know, why shouldn't we open our societies to computer scientists as well that are interested?
No. Francois, here.
Who's that?
It's me, Chris here. Francois, I'm strongly disagreeing. If you close the door for the computer scientists and artificial intelligence, I think you are on a lost way.
No. I said that we should open the door. I didn't say we should close the door.
Oh, yes.
I said we should open the door.
Sorry, I heard you saying not closing the door.
No. I said, why don't we open the door to computer scientists?
I'm absolutely in favor to do something like this, since this artificial intelligence is artificial. I'll give you one example out of my experience. We have had an European call where we were looking for artificial intelligence and come up with algorithms to predict progression in osteoarthritis. The computational scientists were coming up in the first instance in analyzing the data with 3 parameters that were outstanding in the data sets they have analyzed. And I'm making this joke, and they are aware of, I'm making this joke. The 3 outstanding parameters was clinical site, participant number, and sex of the patients. Great. Does it mean clinically anything? Most probably not. I would say. So we need to educate them in a way that we are using, what we heard in the free talks also today, that we are using data, integrate them, and bring them to meaningful, clinically meaningful context that we can use in daily practice, in clinical trials, in diagnosis, whatever you want to have in the whole thing. And the talks were really very impressive in focusing on this. Neil started with the basics, and then Matt and Philip were alluding to some applications. That's the way we should go for. And sorry, Francois, again, I apologize. I got you completely.
It's all right. It's all right. And thank you for these comments. And I think that leads us to closing on those comments. I think we've seen some great questions, especially great talks. I have now just a couple of slides to conclude. I want to share with you this publication, which is from today. So regarding osteoarthritis, we've just published the first ankle arthritic osteoarthritic change classification in weight-bearing CT in the journal Foot and Ankle Clinics. And this was a piece of work that was driven by Professor Richter, again, who was at the origin of the International Weight-Bearing CT Society, and members of the board. If you have some time, of course, I encourage you to read that. So can we have the next slide? Yes, and that's just the final thank you slide. So I want to give my thanks and applause to all the great speakers that we had, and we all look forward to interacting and working together in the future. Thank you, everyone.
Thank you, everyone, indeed.